Welcome to The Explainer. Today, we're mapping out a strictly high-yield diagnostic pathway. We're going to help you master those tricky clinical and legal matrices you absolutely need for that 270-plus score. We're cutting out all the fluff, getting straight to a peer-to-peer breakdown of informed consent, capacity, and confidentiality. Let's get right into it.
Here's our agenda. We'll hit the pathophysiology of capacity, consent exceptions in minors, a pediatric emergency clinical variance, confidentiality and protective boundaries, the Tarasoff rule with mandated reporting, and finally, a clinical variance on intimate partner violence.
All right, Section 1, the pathophysiology of capacity. So to demonstrate true decision-making capacity, a patient actually has to clear 4 strict sequential hurdles. And remember, this isn't some global assessment, right? It's highly specific to the decision right in front of them. First, they've got to understand the relevant clinical information. Second, they need to appreciate the severity and the actual consequences of their specific situation. Third, they have to reason rationally through their treatment options. And fourth, they need to express a consistent choice. If a patient checks all 4 of these boxes, well, their autonomy is paramount, literally even if they are refusing life-saving care. Moving on to Section 2, consent exceptions and minors. Okay, so when exactly is standard informed consent legally bypassed? Just remember the WIPE mnemonic. W is for waiver. That's when the patient explicitly says, hey, don't tell me. I is for incompetence, meaning they completely failed that 4-step capacity flow chart we just looked at. P stands for prioritized emergency, where any delay literally means serious harm or death, and T, that's therapeutic privilege. Now, be careful here. It's a highly restricted exception used only when disclosing information would cause severe, immediate psychological harm. Now, check out this strict dichotomy between standard parental consent and absolute legal exemptions. The standard mandate, it says you need parental consent for anyone under 18, plain and simple. But you completely bypass this if the minor is legally emancipated, so if they're married, in the military, or fully financially independent. Plus, condition-specific care overrides parental rights completely. So if a minor comes in for STIs, contraception, pregnancy, substance use, or needs emergency stabilization, you absolutely do not need parental permission, period. Which brings us to Section 3, clinical variance, specifically a pediatric emergency. Let's test this out. Evaluate this presentation. An unaccompanied 16-year-old presents with severe stridor requiring immediate, complex pediatric airway management. So what's the most appropriate next step? Is it A, wait for parental consent, B, seek a court order, C, transfer the patient, D, intubate immediately, or E, consult the ethics committee? If you guessed D, intubate immediately, you nailed it. Let's break down why. Choices A and B, waiting around for parents or a judge, just waste critical physiological time and directly violate non-maleficence. Choice C, transferring a patient with an unstable airway, that is a massive clinical error. No way you do that. And choice E, ethics consults. Those are strictly for non-emergent disputes. In a prioritized emergency, immediate physiological stabilization always supersedes the standard parental consent mandate. Action is everything here. All right, Section 4, confidentiality and protective boundaries. You know, HIPAA is powerful, but it's not absolute. The WAIT-A-SEC mnemonic cleanly maps out the definitive boundaries where patient confidentiality is legally overwritten. You are required to report wounds from weapons, like gunshots, automobile-impaired driving, infectious reportable diseases, think TB or HIV, the Tarasoff duty to warn, abuse, suicidal intent, elder abuse, and child abuse. If you hit literally any one of these triggers, confidentiality is broken, no exceptions. Next up, Section 5, Tarasoff and mandated reporting. This Tarasoff duty to warn, it is heavily tested for a reason. The absolute threshold for breaking confidentiality requires a threat to be exactly 3 things: specific, imminent, and directed at an identifiable individual. Vague, general statements like, I hate everyone, just do not cut it. You only cross that legal threshold to breach confidentiality when there is a clear, identifiable victim in immediate danger. Now, let's look at a critical divergence in mandated reporting that honestly trips up a ton of clinicians. Vulnerable populations, specifically children and the elderly, carry an absolute mandate. You have to report to protective services completely regardless of their wishes. But competent adults experiencing intimate partner violence, they completely retain their autonomy. You actually cannot report domestic violence to the police without the competent patient's explicit consent. It's a huge, crucial distinction. And that leads right into Section 6, clinical variance regarding an intimate partner.
Let's evaluate this scenario. A competent adult discloses active intimate partner violence. They remain in a highly dangerous environment, but they explicitly refuse police intervention. What is the absolutely correct next step here? Is it A, mandated police report, B, respect autonomy and offer resources, C, notify their spouse, D, an involuntary psychiatric hold, or E, call adult protective services? The correct choice is B, respect autonomy and offer resources. Why exactly? Well, choices A, C, and E might be well-intentioned, but they actually represent critical ethical and legal failures. Breaching confidentiality without consent and a competent adult is a direct, massive violation of autonomy. Choice D is wrong because their capacity is fully intact. You simply must respect their autonomy, provide a safe space, and offer safety planning. So going forward, how will you balance this stark clinical reality with your fundamental duty to do no harm? Master these matrices, and you're not just going to pass the boards, you are going to be a far better clinician.